and welcome to the program. This is a consensus-based approach for the use of traditional negative pressure and single negative pressure. The faculty for this program is going to be Teresa Hurd, which is myself, and I'm a professor at DuVille University in Buffalo, New York, as well I am the System Director of Clinical Education, Inpatient Wound Care, and Diabetes at Catholic Health. Also, the second faculty member will be Dr. Robert Kirshner. Dr. Kirshner is the chairman and Harvey Blank professor. He is at the Dr. Philip Frost Department of Dermatology and Cutaneous Surgery and director of University of Miami Hospital and Clinical Wound Center, University of Miami Miller School of Medicine, and that's in Miami, Florida. This is our faculty disclosures. And this is the program information. This program is being provided by North American Center for Continuing Medical Education. This is a supported educational grant by Smith & Nephew. Our learning objectives for this program are to define the different methods of negative pressure, both traditional and single negative pressure. And I'll talk a little bit more about that. We're going to describe the modes of action of both traditional negative pressure and single negative pressure. Dr. Kirshner is going to review the validated decision pathway to help you with the selection of appropriate negative pressure. He's going to work with you and examine recently published data that compares traditional negative pressure and single negative pressure. So let's get started. Let's look at what's happening in the wound world. And this is what we're finding. Our world is changing. And so are wounds, and so are the people we're taking care of. As people are getting older, what we're finding is there's more and more comorbidities. And what's attached to comorbidities but wounds? We have a high propensity and a high prevalence of comorbidities such as diabetes, and this is a global threat to the world. With that comorbidity comes often wounds. These could be surgical wounds that don't heal. These could be diabetic foot ulcers that are absolutely attached to the patient who has diabetes. These wounds affect patients' quality of life. They affect them from a disability perspective, and they actually cause them a lot of pain and suffering. Some of the work I've done in the past is actually looking at disability adjusted years for people who live with comorbidities and live with wounds. So what we have to think about when we're looking at these comorbidities and these wounds is the impact to the patient means that we want to get these wounds healed as quick as possible. The longer the patient has the wound, the more impact, the more pain, the more suffering, the risk of more critical things happening to the patient, such as amputation and sepsis. In addition to that, the more it costs the healthcare organization. The longer the patient has a wound, the more complex it gets also to heal these wounds. So that's important when we're looking at how we want to treat wounds and what kind of treatment we choose for these wounds. So what is the impact? Well, 6.5 million patients in the United States alone are affected by chronic wounds. That is 1 in every 38 adults. And interestingly, there is more people who live with chronic wounds than live with heart failure. So this is a very impactful number, and it's a number that we have to start looking at chronic wounds as we do other diseases. So that asks the question, how do we measure up with chronic wounds? How do we take care of them? How are we doing with healing times? How are we doing with treatments? What is the cost to not only the patients, which I talked about in the other slide, but what is the cost to the healthcare system in general, no matter what country you live in? In the United States alone, we spend close from $9.1 billion to $13.2 billion just taking care of diabetic foot ulcers. You add that cost to also taking care of the patient with diabetes, and you can imagine the cost this is to our healthcare system. Venous leg ulcers, $14.9 to $17 billion a year. And pressure ulcers, $9.1 billion to $11.6 billion. And when you think of the pressure injury, you might look and say, oh, well, that number is a little bit lower. That number is a little bit lower because we're actually only talking about patients in hospitals, not the cost once the patient goes home with the pressure injury. So that's just the financial numbers to what we're paying to take care of chronic wounds. Why is this important? Well, one of the things we want to do when we take care of chronic wounds, as I've alluded to, is to get our healing times as quick as possible to avoid any other issues for that patient. And we have found that if we start negative pressure early on, and if we use negative pressure, we not only have healing times improved, but in fact, we decrease length of stay in the hospital. So again, these are really important things to start to look at when we look at chronic wounds. No longer do they kind of sit out there by themselves. If you're looking at wound healing and you're starting to look at your numbers in wound healing, what you want to start to think about is, what are the barriers to wound healing? In other words, what can stop a patient from healing in a trajectory that would make sense for that wound and that patient? We know that psychological plays a huge impact on patients with chronic diseases. Patients get tired, they get tired of treatments. So when you go to choose a treatment for a patient, you have to think about, what is the psychological impact of this treatment? Sometimes in healthcare, we forget that. We're so used to doing, that we might stop and think about, what does it mean if this patient has to walk around with the machine? In other words, clinically, I know this might be the quickest way to close this wound, but what's the impact for the patient? What's the safety issues for the patient? What if it's a younger patient, is the developmental issue if I'm starting something such as negative pressure? What about clinicians? Is every clinician able to do the type of treatments and assessments that we need to heal patients in a timely manner? Have we provided education? And this isn't just for wound treatments. This should be a quality indicator in your organization as well for things such as pressure injuries. So I have quality indicators in my system that look at the education for our clinicians as a quality indicator, with an expectation and a measurement that our clinicians know how to take care of patients with pressure injuries and prevent pressure injuries. Well, if we're starting to look at treatments and treatments such as negative pressure, if we're looking at what we call traditional negative pressure, the literature has told us, and many of you have experienced this, that it might not be such an easy treatment for patients to do. In other words, if I do this skill, and the skill is a little bit more complex than other skills, then perhaps if it's not reinforced continually, or it might be something that's a hard skill for me to take, I won't be able to do that. And we have found with negative pressure that there can be an inconsistency in the education across large organizations. And of course, that will spill to the patient as well and cause problems with the patient. And this, of course, is something we look at when we look at education and look at the type of treatments we're providing for our patients. And what about the clinicians themselves? What do they expect? Hospitals are very, very busy. We're just coming out, and I want to say we're coming out of a pandemic, and it has increased clinicians' time unbelievably. So how much time do our clinicians have to take care of these patients? And what can we provide for them? What do they expect from us to help them help patients heal? And then organization. You have to look at your organization and your culture of your organization and how ready they are or what they can manage. What is their capacity to help wound healing? Do you have an organization that has collaboration between providers and nurses and patients? So these are some of the other things you want to look at when you're trying to figure out, do I have issues with wound healing? So let's talk about negative pressure. Negative pressure has been around for quite a few years now. I was a very young nurse when it first started coming, and I'm no longer a very young nurse, so that means it's been at least 20 years or plus. And what has negative pressure given us? Negative pressure has been something that we could use that we consider a wound closure system. In other words, it provides negative pressure to the wound site to promote healing, both in acute, we use it in acute, and chronic wounds. And once again, we have traditional negative pressure and we have what we call now single-use negative pressure. Well, over the last 20 plus years, we have learned exactly what the advantage is to negative pressure. So when you're choosing a treatment for your patient and you have a patient that has a wound, you need to make that assessment on the patient like you would for any kind of treatment. You want to take in the psychological. You want to take in the wound itself, and you want to make an assessment of that patient to how much you can afford a risk if you don't use a particular treatment. I use pharmacology as an example for this. In other words, if you order a medication, if I order a medication for a patient, I will choose the medication based on my assessment of the patient, based on my clinical decision and diagnosis of what the patient has, and then the risk of failure. In other words, if I have a patient who's immune suppressed with a wound, such as a diabetic foot ulcer, in a distal area where blood flow is not that great based on the comorbidity, based on anatomically where it is, what is my risk for failure with this type of wound? Can I afford this wound to go on for a year? Is the risk too high for the patient from the perspective of getting into trouble, such as sepsis, osteomyelitis, or, God forbid, a limb amputation? So that's the first thing I want to think about. And then when I think about something such as negative pressure, I know that I have proven advantages to this. So what are some of the advantages that help us along this pathophysiology of wound healing? Because remember, the patient needs as much support as we can give them to take the wound to closure. So by applying a mechanical force, I can pull this wound together. It increases that wound contraction. In other words, it's going to pull the wound together. Interstitial edema. Edema is your enemy when you're trying to heal a wound. In other words, if you have edema around that area, you're going to have problems getting blood flow, and you're also going to have problems getting the cells we need to do the job to help the patient heal. So the reduction of interstitial edema not only allows for perfusion, but it also allows for the cells to get to the site and do what they need to do. You have an increase in circulation and perfusion, not just because of the edema, but because of that zone of hypoxia that happens. And the answer the body will respond is with an increase in angiogenesis. And angiogenesis is when we start to form new blood vessels. New blood vessels increase perfusion. Removing all that exudate. Many of you work with wounds that just pour exudate out. Nothing will remove exudate like a machine. And that mechanical pulling off the exudate removes exudate, debris, bacteria, and most important, will close that wound off and provides a closed, moist wound environment for all of the healing to happen. So those are the advantages to using negative pressure. And then knowing that, I make a decision who gets negative pressure. And you have to, as I said, we take in all of the issues around what happens in your organization and your patient's ability to manage such of a treatment. And this, of course, is where single negative pressure has come in, and I'll talk about that. Once again, this slide is just demonstrating exactly from a physiological or a pathophysiological perspective what negative pressure does do for our wound. In other words, what can this treatment do for my wound? And what we do know is it does enhance healing, thereby decreasing your healing times. Whenever I decrease my healing times, what I do then is I decrease the financial impact and I decrease the clinical impact on the patient themselves and all of the risks of walking around with an open wound. Now, single negative pressure is what we call PICO, is an example of single negative pressure. In my experience, I have used a great deal of PICO, and I've used it on a global level as well. So I've used it on all kinds of patients in all kinds of areas, just like negative pressure. And what we found, because it wasn't just me, I work with many clinicians, was that PICO actually, in fact, gives you the same outcomes that we would expect for negative pressure. Except the difference is you don't have that bigger machine. And I'll show you some pictures later of it. If you're not familiar with single negative pressure, then you'll see there's a big difference in the machine. There's a big difference in the actual dressing itself and the time it takes to put that dressing or apply that dressing. In other words, it's a simpler dressing to apply. One of the things we can do with PICO, and we do this with negative pressure as well, is you can also use a dressing or whatever filler you want to use. So if you make a decision that your patient, in fact, has too high of a bacteria burden and you want to treat it with a piece of silver, then you can use silver. So you can use whatever filler you want on single negative pressure. So this slide gives you the difference between traditional and single negative pressure. In other words, it'll show you what the difference is. So with traditional negative pressure, you have the choice to put in as a filler an open cell sponge or a piece of gauze. You then put the sealed adhesive drape over top of it, and you have this subatmospheric pressure delivered. Single-use negative pressure has a set level. So the difference here, traditional negative pressure, I can put 125 millimeters of mercury, I could put 75, I could put 50. With single-use negative pressure, PICO, it's always 80 millimeters of mercury. So that's a set level. It's a single patient use. And in addition to that, the therapy is 7 days. In other words, that therapy will go on 7 days. Well, what's the difference between traditional? Is that dressing needs to be changed every 3 days. So that machine, it's either a rental machine or you own the machine, can then be cleaned, recalibrated, and used for another patient. Where single negative pressure is exactly what it says, single, only for that patient, and it goes for 7 days, and then it's disposable. The dressing actually is changed when the dressing itself gets full of exudate. In other words, you would need to fill it when you get exudate, and or if you used a piece of silver that was a 3-day dressing, you would change it in 3 days. But if you are just using PICO, it can go for 7 days. Once 7 days is up, the machine is then disposed, and you use another machine or another PICO for that. Now, some of the other dressings is around exudate. Your traditional negative pressure carries a lot of exudate or holds a lot of exudate, and you won't get that with PICO. So you won't be able to have huge amounts of what I call copious or large amounts of exudate. It tends to be a dressing that we use for medium or lower levels of exudate. The choice filler is you can make that decision, and again, you can with both. The length of dressing for your single disposable can be anywhere from 3 to 7 days, where every 3 days is your traditional negative pressure. Here's another thing. We have found, of course, because the dressings are not quite as invasive, that they're actually more comfortable for patients. So they're less painful dressing change. It's an easier machine to walk around with because it's a tiny little, really tiny little, I call it like a little iPod. I took care of a great deal of patients in my clinic that had what we call pilonidal sinus. And we used to like to put negative pressure on them. And I particularly had a surgeon who would do surgery and wanted to put negative pressure, because we found when we did that, our healing times were decreased significantly. These are usually on very young patients. So often they'd be in university, they'd be in school, and they did not want to walk around with a large machine going back and forth to school. So here was a really good population that from a compliance perspective, when I switched them to single negative pressure, I was able to deliver negative pressure to the wound, but at the same time, I wasn't giving that psychological impact by having to carry this big machine around high school where possibly people would look and there were body image issues. So this is another thing. When you choose a drug, you may have two drugs that do the same thing, but one drug might cause side effects that will cause the patient to not adhere to the treatment. And this is what we found with negative pressure. In other words, if I could use single disposable negative pressure, I had a higher compliance with this kind of patient. And that's just an example. The other example is the economical or the financial impact to the organization and the ability to get them. So these are dressings that sit on a shelf. So all the nurse has to do if you're inpatient or a clinic or even home care is it's treated like a dressing. You just send it like a dressing. There's no rental, no problems with trying to get it to people's houses or using this one or recalibrating that one. You just pull it off like you would a box off a shelf and put the dressing on the patient. In addition, it's definitely a more economical negative pressure. So all things equal, the question comes, which one do I use? They both give us negative pressure. And this is where you start to use your clinical skills and your assessment of the patient to make a decision, which one is better for my patient. If both of them are negative pressure, then you start to take in things such as financial, efficiency, cost, and patient compliance, or how impactful the treatment will be on the patient. As I've mentioned, when you look at conventional traditional negative pressure, you can use gauze or foam in them. You can do this as well with single-use negative pressure. So if you need to fill in a space, you can choose gauze, you can choose foam. We've used hydrofibers, we've used all kinds of things when we're treating patients. So how does, when we start to look at innovation, and negative pressure itself was innovation some years ago, when there was no such thing for wound therapy, when we just sort of put dressings on and crossed our fingers. Now we have dressings and treatments that actually interact molecularly at that molecular level to help with healing times. Based on that, we can say that innovation actually does bust through one of the barriers to wound healing. As your organization, as a clinician, if you want to continue to reduce these barriers to wound healing, you have to be up and ready for these kind of innovative treatments that come. So this is the new generation, or this is what we call the new generation of negative pressure. It's the single use that I've talked about. It's clinically effective. It's cost effective. It has a portability for patients to use one application, one operation, and better access and cost for patients. How does it work? Well, here's the revolutionary, and I'm certainly not an engineer to talk about it, but what I do know is you have a soft silicone dressing. That soft silicone dressing is very gentle on patient's skin, so we don't have to worry about that. In addition, you have this super absorbent dressing that actually absorbs 20% of the drainage and 80% goes into evaporation. So that's how you manage your drainage. Once again, you want to always be sure to understand that you're not going to be able to have large exudating wounds that use this. So all things equal, we have clinical equivalency, as I've said. We have pressure precision. So again, we have 80 millimeters of mercury. And what we have found out that we can't really say there is a pressure that 100% is going to create quicker healing or be effective more from a treatment perspective. We can make a decision for our filler, and we can ensure that we have good patient compliance. So how do I make that decision? Well, you're really lucky because Dr. Kirstner is going to talk in a few minutes, and he's going to talk about a really nice decision tree to help you make this. So you don't have to remember this or take notes. he is definitely going to help you with this. So I'm going to conclude my end with a quick case study, just to give you an idea of one of the incidences. This was the type of negative pressure we used. We had a gentleman who was 70 years old, post knee replacement, over 9.5 months. So he had it 9.5 months ago, and it dehisced, and he had an open wound that went on for quite a bit of time. He'd been on some prednisone to manage his arthritis. And think about the cost of 9.5 months of having an open wound. Never mind the impact to the patient, the pain, the dressing changes, the barrier to life activities, the worry. Patients worry when they have wounds as well. What we had after we applied negative pressure was we had it healed and completely closed in 7 weeks. So think of the cost to that as well. Here's what we found out. 3 months later, we wanted to look, and we still had the incision closed. So we can say he healed. We, of course, discharged him. But here came the decision. I wanted negative pressure. You can see the upper knee, the wound that's open. And you can see it's open on a limb that's moving, on a limb that keeps kind of, constant opening it up again. In addition to that, it was a knee replacement. So we do want our knee replacements to go through physiotherapy. And the reason we will need physiotherapy is to get those tendons working again so he can have full range of motion. He was on prednisone, so he was immune suppressed. So there was a risk here. I'm not even going to go into antibiotics because I could talk about them for an hour, the amount of antibiotics we use for wounds when possibly we could use other means to close these wounds quicker. But here's the thing. I knew I wanted negative pressure to get the contraction, to get the protection, to seal it off, to get more perfusion to the site, to allow him mobility. Which negative pressure did I choose? I chose, he didn't have a lot of drainage, he had a small amount of drainage. I chose the negative pressure that was less impactful to the patient, increased mobility, increased compliance, and in addition, allowed for easy dressing changes and disposability of the unit. So this was one of our first patients. We used PICO, and you can see in 7 weeks, he was completely closed, and 3 months later, the incision stayed closed. So these are kind of the things you think about when you make a decision around negative pressure. Who gets negative pressure? And then now I have a choice. I can use something much more portable, higher level of compliance, much more efficient and effective versus often the traditional. We'll never get rid of traditional. You'll still have wounds that need traditional, but now you have another option. I'm going to let Dr. Kirstner talk now because he's going to tell you a little bit more about research and some decision making. Thank you.
Thank you, Dr. Hurd, for that great presentation. And it's a pleasure for me to give my part of this webinar, where I'll be talking about unlocking the real potential of negative pressure wound therapy. Now, as we were aware of the common chronic wounds that we see in wound clinics, the two most common are venous leg ulcers and diabetic and neuropathic foot ulcers. And they're quite common. In fact, just to give some perspective, in the US alone, recent data from several years ago suggested that there were about 2.2 million venous leg ulcers each year, and that not only are they prevalent, but they're costly. If you look at the incremental cost between a matched patient with a venous leg ulcer and without, the venous leg ulcer costs about $6,000 to $7,000 per patient. And if you do the math on those 2.2 million and multiply it by $6,000 to $7,000 per patient, you get a total incremental cost of up to $15 billion annually for venous leg ulcers. Now, diabetic foot ulcers are also common and costly, but they also carry with significant morbidity and even mortality. And we know from data that's emerged over the last decade ago that foot ulcers from diabetes have a higher mortality rate, estimated at above 30% over 5 years, than many cancers, such as prostate and breast cancers. So we're talking about common, costly, and highly morbid and mortal diseases that we're seeing in the wound clinic every day. So providing the best possible care for these wounds is going to be critical to improving the lives of our patients and helping the healthcare system at the same time. Now, the standard of care for venous leg ulcers and diabetic foot ulcers has been well defined. For venous leg ulcers, compression therapy is really the cornerstone of good care. And for diabetic foot ulcers, excellent evidence exists for offloading and with debridement, both initial kind of comprehensive debridement, then followed by periodic or selective debridement. But even when you deliver this standard of care, compression, as well as offloading and debridement, unfortunately, not everybody heals. It does speak to some degree to the difficulty of taking care of these wounds and the refractory nature. And if you look at the data, up to a quarter of venous leg ulcers and about a third of diabetic foot ulcers fail to heal in a significant amount of time. We're talking about 6 months. So clearly, other therapies are going to be needed to help take this population of patients and bring them to healing. Now, for many, negative pressure wound therapy is a gold standard for many types of wounds. And this experience and data and its clinical use of negative pressure wound therapy has kind of evolved over the last 30 years or so, where we have a fairly high comfort level with negative pressure wound therapy for certainly many types of wounds. Now, there are different types of traditional, what we call traditional negative pressure wound therapy. And it turns out that when studies have been carried out comparing various different types of traditional negative pressure wound therapy, really, there seems to be very much similarity between the various types. And here's one example of a well-done study comparing one brand Renesys compared to another system VAC. And this was a relatively large study. It was retrospective in nature, but over 1,100 patients were involved in this evaluation. And what they found was that 94% of patients who were treated with the Renesys system achieved their treatment goals. In a similar fashion, about 90% of patients treated with VAC reached their treatment goals. The treatment time was similar between the two groups, approximately 8 weeks to achieve these treatment goals. And when you looked at different outcomes, and we'll pick one as an example here, reduction in wound area, very similar results that the Renesys led to a 65% reduction in area and the VAC led to a 64% reduction in area. And the weekly rate of reduction, again, was very similar between the two systems, 9.7% wound size reduction per week with the Renesys and 9.4% wound size weekly rate of reduction for those treated with VAC. And this, again, were no statistically significant difference. So if you look at these two systems, there were really no significant differences between their treatment goals, and they're quite comparable, but also highly efficacious for some of the complex wounds that were analyzed in this retrospective analysis. Now, interestingly, over the last number of years, new types of negative pressure wound therapy devices have emerged. And among them is this single-use negative pressure wound therapy. And these single-use negative pressure wound therapy, which I'm going to talk about more as I go through this presentation, has the opportunity to address many of those challenges that patients experience with traditional negative pressure wound therapy. So while negative pressure wound therapy, can be beneficial for many patients, it has some drawbacks, including pain, portability, patient experience. And when you use single-use negative pressure wound therapy, there seems to be less pain and discomfort. There's increased portability and mobility associated with these single-use negative pressure therapy devices. And as a result, with this greater freedom and less interruption of activities of daily living, there's improved patient experience. Exemplified by this is this study of 326 home care patients who were treated with one of the single-use negative pressure wound therapy devices, the PICO device. With this PICO device being smaller, more portable, more mobile, 90% were able to shower or bathe with this device. 93% could perform daily activities. Nearly everybody, 99.7% didn't report discomfort during wear. And 97.5% were pleased with treatment with this single-use negative pressure wound therapy. So this novel type of way to deliver negative pressure wound therapy addresses some of the challenges with the traditional negative pressure wound therapy devices. So now, interestingly, while I showed you some data between two types of traditional negative pressure wound devices, the Renesas and the VAC, what about a comparison between these single-use negative pressure devices and traditional devices? And interesting, what I'm going to show to you in the next few minutes is that PICO certainly is as effective and likely more effective than traditional negative pressure wound therapy in the management of very common wounds I highlighted earlier, venous leg ulcers and diabetic foot ulcers. And when you looked at home care patients, that mean reduction in wound area per week was the same with the PICO device compared to traditional negative pressure devices. So several different studies suggest, or early studies suggest, that these may be equal or maybe even perhaps more effective, and certainly easier to apply. 86% of home care nurses found the dressing very easy to apply. And we know that traditional negative pressure wound therapy application may be complicated and complex. So let me stop here and kind of contextualize what Dr. Hurd has told you and what I've told you so far. That there are some improved clinical and patient outcomes. There are some operational efficiencies and quicker patient discharge that occur. And as a result, there are cost savings, both in the actual use and by having resource optimization that may occur. Okay. Now, let's continue to talk a little bit about the PICO device, because it really can and help improve the provision of care. It brings one of the most innovative tools for wound care and can be integrated as an option in wound treatment. It allows better access to negative pressure wound therapy treatment from both a patient and fiscal standpoint, which I'll share with you in a moment. It facilitates discharge processes. So if a patient's in the hospital getting negative pressure wound therapy, traditional style, you can transition them to single use and continue it at home with that single use, and it ensures continuity of care. It improves patient independence and well-being. It demonstrates effectiveness in real-life practical situations. And as I'll show you, has been shown to be clinically effective, which I highlighted some work by Dr. Hurd just a few moments ago, and also a cost-efficient modality for the treatment of wounds that has the potential to benefit both patients with regard to quality of life, symptoms, and overall wound healing. Okay, so we have two types of negative pressure wound therapy, and we know how it works. How do we decide which one to use? So Dr. Hurd and I have been working on an algorithm or a pathway to help clinicians make decisions about when they should use traditional versus single-use negative pressure devices. And the clinical decision-making really has three integrated phases, including diagnosis, assessment and severity, and management. Certainly, the clinical decision-making needs a precise diagnosis and then needs to factor in various costs in terms of human and fiscal costs that are associated with treatment. It's important to assess the risk for adverse outcomes, because that may also impact costs, and that's important to determining what would be the right management. And this management really talks about what type of negative pressure for which patient and when, and the institution of that therapy and the follow-up of patients. So we've published this recent algorithm just this year, And we had a consensus group get together to look at how to incorporate the two types of negative pressure devices. And it starts with, does the wound fit comfortably under one of the PICO bandages, the single-use negative pressure device? If it's yes, then you could consider using the single-use negative pressure device. If it's no, then you'd go on to a traditional negative pressure device. Once if you know that it fits under the dressing of the PICO device, then you have to determine whether the amount of exudate is low, moderate, high. For low or moderate exudating wounds, then PICO dressing would be an appropriate choice, while for highly exudative wounds, you may then go to traditional negative pressure devices. And then finally, if you're going down that pathway of a wound that fits under PICO and is low or moderately exudating, then you have to decide whether or not you want to use a filler or not, because a filler can be used in both traditional and single-use negative pressure devices, the PICO device, but you can also use the PICO device without a filler. And in that case, you just begin the application with the PICO device. However, if you do decide to use a filler, then you have to decide which type of filler do you want to use. Do you want to use gauze or foam? And whether or not you want to have an antimicrobial action. And then based on those previous characteristics, that is the size of the wound and whether it fits underneath the dressing and the amount of exudate, that will determine whether you'll use that filler with the PICO device or the Renesys device. So this algorithm should help guide clinicians in how to think about the two types of negative pressure wound therapy options that exist when you're choosing this for your patients. Now, I wanted to share with you this study that we published about a year or so ago. I was the lead author of this multi-center study that really compared the single-use negative pressure device with traditional negative pressure wound therapy devices on chronic ulcers of the lower extremities. And of course, we know, as I pointed out before, that traditional negative pressure is used across many clinical settings, but it is complicated and difficult to use. There is fairly strong clinical evidence for the use of negative pressure with diabetic foot ulcers, a little bit less evidence for venous leg ulcers. But the real question is how would this single-use negative pressure device compare in a well-performed randomized control trial compared to traditional negative pressure wound therapy device? Was it going to be as good as traditional negative pressure or not? So this was a fairly robust study. It involved patients who initially were screened for venous leg ulcers, diabetic foot ulcers present more than 4 weeks. The venous leg ulcers were somewhere between 2 and 36 centimeters, and diabetic foot ulcers were between a half a centimeter and 10 centimeters squared. Of that population, 164 patients were randomized to single-use negative pressure versus traditional negative pressure, and then outcomes were analyzed after 12 weeks or until wound closure. And this analysis really took two types of analysis. There's one called a randomized or intent to treat population analysis, and the other is also a randomized population, but this is per protocol. Because we initially started out to see whether the two devices were equal, this is called the non-inferiority analysis. And when you're trying to determine non-inferiority, the statistics are done on the per protocol population. That is, you want to make sure that the two treatments, that there's non-inferiority in people that truly received the treatment, because you don't want to get false data just because a person really didn't get the treatment. So that's why with non-inferiority analysis, you use a per protocol population. On the other hand, when you look at superiority, you look at intent to treat population. And these are two conservative ways to look at this data. there were 16 sites in the US and 2 sites in Canada that participated in this randomized controlled trial. And overall, there was a similarity between the 2 groups in terms of age distribution. These were adults age 60 to 60, the early 60s. They were similar in body composition, similar BMIs, and similar in gender distribution between the group that was randomized to the single-use negative pressure and to the traditional negative pressure. And this 80 and 81 represents the intent to treat population, which again is the superiority analysis. So right now I'm going to show you 2 different graphs. This is the primary endpoint, and the primary endpoint of this study was % change in wound area at 12 weeks. On your left is the per protocol population. And what happens is, to determine non-inferiority, we decided before we even started the study that non-inferiority would be anything less than a 12.5% difference between the 2 groups. Interestingly, what we found was that there was more than 12.5% difference between the 2 groups. In fact, with regard to % change in wound area, there was nearly a 97% reduction in wound area with those patients who received the single-use negative pressure device, compared to about a 70% reduction in those who received the traditional negative pressure. So we did not find non-inferiority. In fact, what we did find, looking at the intent to treat population, something that was a bit surprising. We found actually superiority with the single-use negative pressure device. In fact, we found that 39% difference in wound percentage of wound change over the 12 weeks, with a 90.2% reduction in wound change with the single-use negative pressure device, compared to 51% with the traditional negative pressure. So surprisingly, we found a superior result with single-use negative pressure device. And this was statistically significant, not only for % change, but also with regard to other outcomes such as wound depth and wound volume, all of which favored single-use negative therapy devices. We also looked at the survival, and this is a survival of the wound. So less survival is better. In the blue line is single-use negative pressure device, and the red line is traditional negative pressure device over the course of the study, which was a 12-week study. And what you can see from this is that there's a greater reduction in survival of the wound. And once again, with regard to pure numbers, overall, you can see for 45% of patients healed completely with a single-use negative pressure device, compared to 22% with the traditional negative pressure device, also a statistically significant outcome. We also looked at how patients liked or tolerated the single-use compared to the traditional use negative pressure device. On the left 3 of this table are things like satisfaction, what they use against, and comfortability, all of which statistically favored the use of a single-use negative pressure device. And on the right 3 interferes with mobility, reduced activity, and disrupts sleeps. All of these things were worse with the traditional negative pressure device. And these all reached statistical significance. So in addition to seeing a greater clinical outcome with regard to wound size reduction, complete healing, depth, and volume, we also saw statistically significant benefit in patient outcomes, patient-related outcomes. Now, here's an example of somebody who received a single-use negative pressure, a venous leg ulcer, prior to the use. The application of this device, which again is a single-use device that does not have a canister. The exudate is contained within the dressing or evaporates. And then after the 12 weeks, you can see the reduction in the wound size, fairly dramatic in this case. Now, one of the very interesting parts of this study is why. Why should traditional negative pressure device and single-use negative pressure device not be equal? Why was single-use negative pressure device better? So Smith and Nephew went back to the lab. And this is really impressive because we made a clinical observation in this randomized controlled trial, something that was somewhat unexpected. And then the company went back to the lab to understand why this was happening. And what they did in the porcine model, they created wounds and treated them with traditional negative pressure device and single-use negative pressure device. And over a 12-day treatment period with both of these devices, they found what we found in the clinical trial. That is that there was a greater reduction in wound area using the single-use negative pressure device. So confirming in an experimental animal model what we saw clinically, better healing in this porcine model. Now, why is that? Why did that occur? There was not a difference between the percent wound contraction between the single-use and the traditional negative pressure device. Both of devices led to wound contracture in a similar way. But what was found and seemed to be the difference that led to the observation of better healing was that single-use negative pressure devices had an enhancement in epithelialization. In this study in pigs at day 6 and going out to day 12, there was a statistically and clinically significant acceleration of reepithelialization when you use single-use negative pressure devices. You can see this in the photographs that are shown at the bottom and the histology shown at the bottom as well, confirming this improvement of epithelialization. Trying to understand that epithelialization is part of some other ongoing work, but it has to do with perhaps how the dressing goes beyond the wound itself and may draw the wound in and allow epithelialization and migration to occur faster. And also the ability to use this without a filler device, which may disrupt new epithelium that's being formed because the single-use device has the option of using a filler or not using a filler, what traditional negative pressure devices use a filler routinely. So with that, I want to stop here and conclude and just remind you that all of us today in every hospital in virtually every country use negative pressure wound therapy to help our patients. But new systems exist. New single-use negative pressure devices have an opportunity to improve our patients' lives, and in certain wounds, in certain situations, seem to even have a beneficial clinical effect on healing. So what Dr. Hurd and I tried to do is to build up to this idea of utilizing both of these two different negative pressure devices and provide an algorithm, a pathway to think about when you should consider using single-use negative pressure wound therapy devices for your patients, because we're confident from the clinical data, from the laboratory data, and from our clinical experience is that by including this technology in the treatment of your patients will have better outcomes. Thank you very much for your attention.